those of you who are here, thank you so much for spending an hour of your Friday with us. My name is Narjis Zahori Dillon. I'm the Executive Director here at Crisis Support Services of Alameda County, and we're so excited to offer 10 of these Lunch and Learns this month. And we've learned so much being together in community with our panelists, with our participants, and it's been a great connecting experience during this, I would say, otherwise difficult time to spend September focusing in this way on various topics. And thinking about our theme, today's panel is really something that inspired us to it was the underlying theme behind all of our efforts, was really to think about the ways in which suicide prevention shows up in our diverse communities and the ways in which social justice impacts suicide prevention. So we're so thankful to be able to learn together today from our lovely panelists. And our moderator today is Mercedes Coleman. She is the Director of Community Education here at CSS, and she's been with the agency for 20 years. Really, this is her life's work, and she's so passionate about educating young people as well as community members on the ways in which they can be part of suicide prevention. And we hope that that's why you're with us today too, is that you know that all of us can play a role in suicide prevention. And for those of you who might be new to our agency, Crisis Support Services of Alameda County has been around just over 50 years here in Alameda County. Our offices are in Oakland, and we serve the community through various programs like a crisis hotline, community education, and clinical services. There's a link to us in the slide that's up right now, crisissupport.org, if you want to learn more. And in just a moment, I'll be turning off my video and handing it over to Mercedes, who will start the panel. But I am going to drop some links to our social media in the chat so you can follow us and know what we're up to all the other months of the year. And we do have programming that's available to the community all the time. Thanks again for being with us today, and we look forward to spending the next hour with you. Go ahead, Mercedes.
All right. Hi, everyone. Thank you for being here today. And we're really thrilled to be able to have our three guests. We have Felicia Carr, we have Dr. Sherry Moloch, and we also have Meg Lien, and from Santa Clara Behavioral Health. And all three, we're really lucky to have them today to be able to share their stories, their experience, and their knowledge with regards to how to better serve our community, how suicide prevention can better serve our communities of color. So we're all really excited to have them here, and I really appreciate their time and participation in our Suicide Prevention Month event. We're going to begin our first, we're going to have 3 presentations, and then after after our last one, we'll, if time allows, we'll take some questions from the chat at that moment. We'll begin first with Felicia. Felicia Carr is the owner and founder of Accessories by Shahara, based in Oakland. And I first met Felicia actually at a Suicide Prevention Month as well last year. She had put together a community event, and our agency was able to have a presence there. And I was just really happy to be able to participate in her event and to be able to really see her advocacy for the community with regards to mental health and suicide prevention. And we really appreciate her being here to be able to share that story behind that event. And I'm going to go ahead and pass on the mic to Felicia. Thank you again for being here.
You're welcome, and thank you for having me. As Mercedes said, my name is Felicia Carr, owner of Accessories by Shahara. So my passion as far as suicide prevention, it really flourished last year. In 2012, I had a nephew who died by suicide. In 2017, I had another nephew die by suicide. And in 2019, I had a younger cousin who died by suicide. And it was at that point to where I figured I needed to do something. It was happening too often to too many people. just, I mean, it was just happening, just seems like every day. And I just felt like I needed to do something. So I decided to put together a suicide awareness event titled Be Here Tomorrow. It was just to allow the community to come out. It was a free event to receive information, to hear other people's story, to let them know that they're not alone. It's happening every day, and it's happening more often times than not. And we needed to stop, and we need to bring awareness to it. It's a very taboo subject. No one really wants to talk about it, but we need to, and it needs to be discussed. But basically my event, I had Dr. Roche Brown. She came out and she was one of the key speakers, as well as Tia Barnes. She came out and she spoke as well. And it just touched on mental health. It touched on suicide in the African-American community and what we can do to make it stop. As you can see on the slide here, each one of those chairs represented my 3 family members that died by suicide. So that was, to honor their memory at the event. I was actually very happy with the event, with the audience, with the amount of people that attended. I was very happy. There was a lot of information that was passed out. There was a lot of people that came that was open to discussion, that was open to talking about it. It was an amazing event. I look forward to doing it this year, but due to COVID, I had to put it on hold. So hopefully I can do it again next year. You can actually go to the next slide. So that's Dr. Roche Brown, and those are a couple of the members, a couple of the attendees that were at the event. That's my family on the left side, me and my husband, 3 kids. You can go to the next slide. So those are some of the speakers that we had at the event. That was the people that was in attendance. You can go to the next one. That was also a speaker that was there at the event. She was speaking as far as she had dealt with suicide in her family as well, and she was one of the keynote speakers. You can go to the next one. That was also just a picture of the people that was in attendance, and it looks like someone was speaking as well. But one of the key points as far as the suicide prevention, I went online and I did a little research. So I noticed that among Black youth, from 5 to 11, the rate of them committing suicide is increasing faster than any other racial or ethnic group. Also, researchers determined that from age group 10 to 19, that it had nearly doubled from 2007 to 2017. So it's at a point to where we need to bring it to the forefront. We need to get a hold on it and kind of, put a stop to it. So I'm just here. I'm happy to be here. I'm nervous, as you guys can probably see, but I'm just honored to be here and be on the panel and sit in for the meeting. So I'm honored. Thank you.
Awesome. Thank you so much, Felicia, and thank you for sharing your story and also for being able to share your story about your loss, and being able to show what advocacy can look like, and being able to pull a community together to be able to have this conversation. I was there at your event, and it was beautiful. It was beautiful to be able to see all of these people walking in and just connecting, sharing information, and being able to just listen to all of your speakers and what they had to provide to the community. Thank you for being such a wonderful mental health advocate within our communities.
You're welcome, and thank you for all that you do.
Thank you. All right. Our next presenter is Mego Lien. She is the Suicide Prevention Manager at Santa Clara Behavioral Health, and one of the reasons why her the work that she's doing in her county was really inspiring has to do with how they have been working on applying a cultural lens to their suicide prevention programs and their mental health programs as well with regards to educating the community. And it's been really inspiring to watch. And our own suicide prevention program and education program at our agency for our county in Alameda County is also starting this process as well. So being able to watch what's happening in another county has just been, it's just been really inspiring. So Mega, thank you so much for being here today.
Yeah, thank you, Mercedes and CSS for inviting me. I have to say it's been, even though you're so close to my county, you know, I hadn't had a lot of interaction with you, and it's been really fun to get to know you and start working with you a little bit more and see what's been going on with suicide prevention in the Bay Area. And thank you too to Felicia for kind of sharing your personal experience and adding that very personal kind of touch to this panel. I'm really coming at this at a very different perspective. So as Mercedes mentioned, I manage the suicide prevention program for County of Santa Clara, which is in the South Bay, close to Alameda County, but not the same county. We have a population of about 2 million people, and it is very diverse in a lot of ways. Just racially, ethnically, we're about 30% Hispanic Latinx and 30% Asian, with a very large Vietnamese population. So next slide, please. So one of the questions that Mercedes kind of asked of the panelists was, what were some of the barriers to doing suicide prevention work for communities of color? And I had an example that came to mind, which is really, I report annually to our county's Board of Supervisors and kind of tell them what's going on with our program and in the county with regard to suicide. And last year, the board posed 5 questions to our program to work on and to respond to during this year's report. And 4 of these 5 questions focused on why the suicide numbers in our county were highest among older white men. And this is a question that, you know, I've gotten from other people, other stakeholders as I've been doing my work. There's a lot of focus, and that's kind of typical, and it's also understandable from a policymaker's perspective. You know, if you're a policymaker, you really want to be going for the largest impact when it comes to your population count. Our county suicide data is reflected in the national data too. And for this reason, you know, with suicide kind of numbers being higher among older white men, the field has traditionally focused more of its research and its programmatic efforts on this group. But then that also begs the question of who is left out. And Mercedes, I think you're gonna have to click a few more times for all of these pictures to come up. I mean, we know that there's a lot of different minority groups that are disproportionately affected by suicide. And this is just some pictures of representing those groups here. So next slide, please. So I really think that this cultural lens begins with the data that you look at. And when we're in data speak and we're talking about equity, it means that we're not just looking at the percentages and the kind of overall counts of who's affected by suicide, but we're also looking at rates. Because rates are a way to even out population numbers so that you can compare the effect of suicide across populations of different sizes. So at my program in the past few years, we've been doing this cultural cross-analysis of our suicide death data. And this is an example of one of the charts that we've been working from here. This is suicide rates in our county over 5 years, 2014 to 2018. And this is race and ethnicity by age group. So you can see on the right-hand side, the white Caucasian suicide rates. The numbers on the right-hand side of each of the bars are the rates. And then if you go from the bottom of the chart to the top of the chart by those colors, those are the different age groups from youngest to oldest. So I just want to point out a couple things here. When we started looking at this data, you can look at the Pacific Islander suicide rates, those numbers over there on the right. That population in our county is relatively a lot smaller than the white Caucasian population, but their rates of suicide are higher pretty much across the board when compared to the white Caucasian population. And it's especially affecting that red bar is TAY, the transitional age youth. And then the young adults, the orange, are the 25 to 34-year-olds. And then if you go to the very left-hand side of the chart, I also want to point out the African-American suicide rates in our county. That blue bar there with the rate of 25 per 100,000, that's the age group of 55 to 64. So this is another kind of population and area of concern that we wouldn't have known if we hadn't done this analysis and looked at rates in addition to our percentages. So if you go to the next slide, it's just one more chart I want to share, which is the method of suicide by race, and ethnicity. And these are percentages now that you're seeing on the right-hand side of each bar. So starting on the left is the white Caucasian population. The red bars are suicides by firearm. And you can see for the white Caucasian population, 40% of the suicides in this 5-year range were by firearm. But now if you look at the rest of the bars, that blue bar you can see kind of represents the majority for the rest of these populations, and that's suicide by hanging or ligature. And so this is really significant because, you know, in the field in the US, there's been a lot of attention with means restriction on gun safety measures because of this effort. But now that we're looking at this cultural data, we're seeing that, you know, thinking about ligature restriction and how we can get more community education out about this among both non-white and younger groups is really important. And so these are two examples of data that we looked at that led to some programmatic changes. In our program, we've started doing outreach to our Pacific Islander community around mental health and suicide. And this year we're starting to look at what ligature restriction might look like. Next slide, please. So our program's in the 4th year of what I really call a cultural competency review and a complete overhaul, I would say. And we're doing this in partnership with Palo Alto University in our county. The challenge for us as a program, you know, I mentioned we serve 2 million people and it's a really diverse county. So our challenge is really how do we address culture when there's so much intersectionality? So people are often or always multiple cultures. And culture expands beyond race and ethnicity. So you're also talking about sexual orientation, gender identity, age as a culture, you know, et cetera. And so this cultural theory or model of suicide has been really helpful to us for this reason. And this came from Dr. Joyce Chu and her colleagues at Palo Alto University. They basically reviewed years of the literature on culture and suicide risk. And they found that 95% of the literature could be grouped into these 3 principles or 4 factors that you see here. And these are on cultural differences in suicide risk. So the first one is really looking for different signs of suicide. So this idea that, you know, different cultures might have different, what they call idioms of distress. So how they're expressing their suicidality might look different from what we traditionally might think. The second one has to do with cultural stressors. So this idea that suicide might be precipitated by different stressors, whether it's the stress of being a minority in this country or the kind of added effect and importance of the social network for different cultures. And the fact that social discord, or when you have conflict within, you know, a family or a support group, this can be extra taxing and stressful for some cultural groups. And then the third one is really looking for the meaning of things. So this refers to kind of the acceptability of suicide in a particular culture, and also thinking about shame as a risk factor for suicide. This can be particularly kind of more potent and pertinent for some cultures, this idea of shame or saving face. Next slide, please. So the rest of this, I'm going to just show you some examples of how we've put the cultural theory and model into practice in our program. This is a screenshot on the left side. You can see this is a clip of an old brochure that we had that we were giving out in the community. And you can see that it's kind of listing some of those typical warning signs that you would think of for suicide. And on the right-hand side is kind of our expanded list, which includes some of those cultural warning signs for suicide or idioms of distress. And I've underlined some of those in red because they refer to some of those concepts I just talked about. So feeling ashamed of who you are in the middle there, or at the bottom, trouble adjusting to a new culture, being treated unfairly because of who you are. These are experiences of minority stress. And then the social discord piece is captured with that towards the bottom, the conflict with your family or community support system. At the top there, unbearable chronic pain. That's also another kind of cultural risk factor that was found through the literature for suicide. Next slide. So we've incorporated these concepts into our community outreach materials. And we've also developed some new materials, and we're making a even more concerted effort now to provide multiple translations of everything we create. So here are just two examples. All of these are available for download at the URL that you see there. This is our LGBTQ plus suicide prevention resource in Vietnamese. And then we partnered with our Office of Immigrant Relations to develop a mental health for immigrants brochure. And this is the one in Spanish that you see here. Next slide. We also do at least we're trying to do now at least one cultural component for our public awareness campaigns. We try to develop and air at least one public awareness campaign per year. And currently the one that you're looking at is a campaign that's on air for the Vietnamese community. Right now it's airing on Viet Today TV, on a couple of Vietnamese radio stations and on social media. So we did testing with our Vietnamese community, and we determined that an educational campaign about the suicide warning signs would be effective, along with hearing from a figure of authority in their community. So we have a physician that you'll see talking. And then it's obviously in Vietnamese, so the script in English is on the right-hand side.
Chồng của tôi trước đây rất yêu đời, vui vẻ, nhưng rồi anh bị mất việc làm, hai vợ chồng cứ cãi nhau hoài.
Bạn thân nhất của tôi trước đây rất vui vẻ, bây giờ anh không muốn nói chuyện, anh không gặp bạn bè, không muốn làm gì hết.
Ba của tôi trước đây rất cởi mở, nhưng bây giờ thì ông cứ ở hoài trong phòng và không muốn ăn uống gì hết.
Tôi biết đây là các dấu hiệu cảnh báo muốn tự tử. Nếu quý vị hoặc người thân có ý tưởng muốn tự tử, quý vị hãy gọi đường dây ngăn ngừa tự tử.
So we also have English, Spanish, and Chinese components of this campaign that are airing on radio and online. And then those URLs down there are the web pages that are associated with each of these languages and cultures. Next slide, please.
Chồng của tôi.
So in terms of trainings, our program in Santa Clara County, we offer 8 gatekeeper or helper trainings from different companies that you might be aware of. We do the QPR, the Assist, Cognito, we do youth mental health first aid. And as part of this cultural review, we reached out to these training providers and we tried to collaborate with them on infusing these cultural theory concepts into their training content. So what you see here on the left is a screenshot from the Cognito online simulation, which is currently being used in about half of our school districts. Last year we trained, I think, 1,600 teachers with Cognito modules. And in working with Palo Alto University, we developed an addendum on culture specifically, which is what you see on the right. And that's included as a resource for all of the training participants to engage with as they're doing the training. Next slide, please. We did have some challenges working with the training providers. They have, copyright restrictions, et cetera, et cetera. So ultimately, we decided also to develop our own tailored culturally competent training series that would work for our program in the county. It's called Be Sensitive, Be Brave, and we have one training for, it's kind of an intro to mental health, and then we have one for suicide prevention. Ideally, they're taken as a series. With mental health first and then suicide prevention. And the cultural concepts are infused throughout. And because we use the cultural theory here, these trainings can be given to any mix of cultural groups. So the picture you see here is the training that we did with our Nepalese community. And we tailored it with specific examples about South Asian and refugee mental health. But overall, the training content and the concepts we're able to use that with multiple cultures and kind of helps us with that intersectionality problem that I was talking about. Next slide. So lastly, this also has been applying to our clinical trainings for mental health clinicians and for suicide risk assessment and management. So Dr. Joyce Chu, as in kind of an outgrowth of the cultural theory, she also developed this cultural assessment of risk for suicide, risk assessment screener. It's called the CAR screener that you see on the left. And the idea is that some of the traditional screeners like the Columbia or the PHQ-9, they're not really taking into account these cultural idioms of distress. And so we can be missing suicidality among some of these cultural minority groups. And on the right-hand side here, you can see how the tool can affect, warning signs that are detected, and then the management, clinical management of suicidality as well. This is coming from a case study with a patient or client who was who is a trans Japanese veteran. So this is all incorporated into this clinical training that we're offering. So last slide, I think that's the work that I wanted to share. I hope you kind of got the message that it is a lot of work to infuse culture across the suicide prevention program and to be really comprehensive about it. It's not just about translation. And it really requires us constantly to be thinking about how can we be more effective and who's being left out of the work. But it really is possible, and I really feel that it's rewarding and that our program is much richer and more effective as a result. We had, from that Nepalese community example, that training, we had some feedback that I'll just end with. They said that we didn't know about the resources that Santa Clara County could offer until now. And this made us feel that someone cared about our specific needs and well-being. So I just thought was a really great way of capturing how rewarding this work is for us.
Thank you so much, Mega. Thank you for all your work. All right, our next presenter is Dr. Sherry Moloch from George Washington University. I had the pleasure of watching her in a webinar a while ago on this topic, and I thought that she the information was also really was really great, and I was particularly inspired by also how by her the examples of how suicide prevention can be tangibly applied within our communities, and I'll let her go from there. Thank you so much for joining us today.
Thank you so much for having me, and I feel like Mercedes and I are friends now. We've had several long talks about other things besides suicide prevention. I want to particularly thank Felicia for sharing her lived experience. It takes a lot of courage to do that, to share your own story and to talk about how suicide intersects with your family. And I also wanted to thank Mego for that wonderful presentation. Such a great example of how you can use research data to shape policy and practices. And I think particularly what's important about what she shared with you all is that it's really important to understand that suicide prevention does need to be done from a cultural lens. The rates in her county are a little different than they are in the national rate. So it's a good example of when you have local data, you can shape the prevention efforts and the treatment efforts to your specific community, because what suicide looks like in her county is different than it looks like, for example, in the county I live in, which is Prince George's County. We have a different demographic makeup. And so I think it's really cool how they were able to do that, and also how they were able to infuse cultural saliency and relevancy into evidence-based programs. And I think the challenge of all of this is that the communities are doing wonderful things, and we don't always know about that in other places. And so one thing that we can do is figure out ways that we can share this information either through social media, through platforms like this, and even in research journals, because that way people can replicate the wonderful work that you're doing there. So I just wanted to applaud both Felicia and Mego for their presentations. I'm going to talk a little bit about the importance of research. Some of this will be a little bit redundant with what Felicia and Mego said. You can turn to the next slide. So one of the things I like to share with people, with clients who are thinking of suicide or who are feeling suicidal at the moment, that for them to remember that this is just a moment in time and not your eternity. And I should say too, I forgot to say, in addition to my research at George Washington University. I'm also a licensed and ordained pastor. My husband and I co-pastor a church together. So I'm going to be talking with you a little bit about how we can take suicide prevention into a faith community. But this is something that I often say to members of my church. And I say this a lot in sermons. I say it a lot when I'm just talking. I say this a lot with clients, is that when you're feeling suicidal, it's just a moment and it feels like an eternity, but it isn't. And when a person feels that way, it's up to family members and community members to step in and loan them some well-being, loan them some faith if you're from a faith community, loan them some problem-solving skills until they're able to function in a better way and function in a way that's going to be helpful and optimize their mental health. Next slide. So this is just going to tell you a little bit about the scope of suicide behavior. You'll notice at the bottom of the pyramid, it says that almost 1.5 million adults have reported suicide attempts, and those are just the ones that are reported. So we know that for every suicide that's reported, there's probably 2 or 3 people who have made an attempt who have not reported it. And of that 1.5 million, about half of them will receive medical attention for a suicide attempt, and about a little over half of those people will be hospitalized overnight or longer for a suicide attempt. And then of those people, a little over, about 11 or 12% will actually end up in suicide deaths. So it shows you that a lot more people attempt suicide than die from suicide, but that we need to take each attempt seriously because we don't have good research on what's the difference between those who attempt and those who complete or who die from suicide. And so that's really important that we need to do a lot of research with that. Next slide. So this is just some national data that's collected every 2 years by the Centers for Disease Control in Atlanta. They do surveys across the United States with a random selection of high schools, and they do the surveys every 2 years. Unfortunately, we're usually about a year or two behind in how up to date the data is because it takes such a long time to collect the data and also to analyze it. So this is the National Youth Risk Behavior Survey, which is, this is a 2017 data, which is the most recent data I could get. So what you'll see is they asked high school students if they felt sad or hopeless most of the time over a 2-week period. And you'll notice if you look at that the total rate is about 31.5%. The females are about twice as more likely to report feeling sad and hopeless as males. There's not really any difference between grades, but you'll notice that Latino, Latinx, or Hispanic youth are significantly more likely to express feeling sad and hopeless most of the time when compared to Black youth and white youth. Next slide. This slide sees similar patterns. You'll see females are twice as likely to experience seriously considering attempting suicide. So this is a measure of suicide intent or planfulness. You'll see again that there's not much difference between the grades, but that there is a significant difference between Asian youth compared to Hispanic and Black youth and white youth. I want you to notice this pattern because when we're looking at feeling sad and hopeless most of the time, Hispanic youth have one of the highest rates. It changes a little bit when you're looking at seriously attempting suicide. Next slide. But when you look at the picture if you look over in the far right, my right, perhaps your left, you'll see that the actual suicide attempts is higher in Black youth. And so the concern about that is not just because of the attempts, but it also suggests that Black youth are less likely to disclose that they're feeling sad or hopeless, and they're less likely to disclose that they're having thoughts about making a specific attempt, and that we probably are either underdiagnosing or missing that these kids are in trouble because they're probably expressing suicidal thoughts and behaviors in a different way. And you'll also see, if you look at the rates for females, it's almost twice as much as males as well. Here you do see some differences with grades where the younger people, youth who are in the 9th and 10th grade, are more likely to attempt suicide than those who are in the 11th and 12th grade. Next slide. So we know that suicide is the leading cause of death for youth ages 10 to 19. We know that suicide attempts rose by 73% and from 1991 to 2017 for Black adolescents, while the injury by attempt rose 122% for adolescent boys. And going back to Amego's data, this is why it's so critical to look at within group within ethnic or racial groups when you're looking at suicide research. If you just look at groups and lump all the youth together, or in her slides, you're lumping together not just racial groups, but also lumping together different age groups, you will miss really important trends, because what will happen is it could be, for example, that this rate for attempts for young Black men is really increasing, but since their overall rates of suicide attempts are lower than another group, you'll miss that trend. So it's really important to disaggregate or separate out data so that you're looking at specific age groups, specific gender groups, specific groups in terms of sexual minorities, and specific groups in terms of race or ethnicity. And then we also know that about 5 years ago, a really important study came out in the Journal of American Medical Association that the suicide rates for Black children between the ages of 5 and 12 are approximately double that for white children of similar age groups. Next slide. We also, as I mentioned earlier, we know that attempt rates are much higher in youth who are members of sexual minorities or who are members of the LGBTQIA group. And so, and this is relatively new information for researchers and for advocates, because up until about 5 or 6 years ago, we did not ask youth about gender expression. We did not ask youth about sexual orientation. And we assumed that youth identified in a binary way as either male or female. So with the asking of the questions about gender expression and sexual orientation and gender identity, this is a good example, again, of when you don't ask that question, you miss really important information. And so we know that youth who are members of sexual minorities have much higher attempt rates. We also know that if you are a member of a minority, of a sexual minority and a racial minority, that your rates are even higher. Next slide. So this sounds like really sometimes overwhelming information. What are we going to do about this? But I'm really optimistic, and I think that we can help children not just survive, but thrive. And I'm going to encourage an upstream approach. So an upstream approach means what we can focus our energies and our effort, not that we take away from treatment, but what can we do to minimize or eliminate risk factors and enhance protective factors so that we can prevent suicide. And we can do that at the individual level, but also at the family level and the broader societal level. Next slide. So one example, and it's just one, is considering developing partnerships with faith communities. My research specifically looks at the African American community, and so I'm going to focus my my talk from this point on that. The Black church is an excellent venue for promoting positive mental health because it's one of the most influential institutions within the Black community. And even though we know that religious participation is going down in many other racial ethnic groups, it has not really gone down very much at all amongst Black Americans. And in fact, 87% of Black Americans are affiliated with the church, and over 60% of Black youth attend church regularly. The other thing that I like about thinking about developing partnerships with faith communities is that the Black church is very youth focused and very interested in working with youth. And they will work with youth in your community, whether they belong to the faith community or not. That's not a prerequisite for that, which is really important. And also, we know that about 70% of members who go to church regularly are women. And guess who decides whether or not kids go to church? Moms. So it's like a captive audience, and it's a place where you can effect a lot of different changes. You can, next slide, please. So why do we include faith communities in mental health care? Mental health issues affect people across all faith traditions. Whether we like it or not, or agree with it or not, faith leaders and faith communities are often first responders. So particularly from people who are from communities of color, may feel much more comfortable going to clergy persons to talk about mental health challenges. And I've also taught in seminaries. And so what I share with my seminarian or my clerical colleagues is that those 6 hours that you took for pastoral counseling and care is not going to qualify you to treat someone or help someone with significant mental health challenges. And so while the faith community can be an important partner, we all can be partners. We each have to figure out what's our role in helping people become whole and holistically healthy. Faith communities tend to care for the whole person and the family. Faith communities interact with people in diverse settings. I jokingly say that, clergy make house calls and other mental health professionals or helpers don't do that. In my own church, I see people on a regular basis, but I also see them in different situations. I see them at Sunday school. I see them during the worship service. I see them when we're having a picnic. Right now, because of COVID-19, we're not meeting, but we're actually interacting with each other more since COVID-19, interestingly, because one of the things we know is protective is social connectedness. And so we're really making sure we stay connected as a faith community. So we do our worship services on Zoom. We do Bible study on Zoom. We started a book club since COVID-19 every 2 weeks. And I do stress management and mindfulness on Zoom every Tuesday evening. And so we have multiple ways of checking. We also have a chain through texting that people check on people to make sure people are doing okay. Congregations also include people from diverse workplaces, including mental health professionals. And mental health crisis, I think we don't realize, is sometimes also a crisis of faith. And so sometimes when people are having challenges in their life, they may also feel that their faith or their beliefs begin to falter. Next slide. So there are barriers, as with anything, to seeking care in faith communities. Sometimes people believe that their beliefs that suicide violates the faith communities or cultural gender norms, roles, norms. So sometimes people think mental illness is a sin or a moral failing. Some people think that suicide reflects a lack of faith or weak faith, or that suicide is a quote unquote white thing. I hear people say that all the time. So people will say, Black people didn't complete suicide, back in slavery. I'm like, yes, they did. Do you know how many people jumped from those ships? There's a lot of people. So we can't always go by what we think happened in the past, because one, people weren't collecting data then, and two, what we understood suicide to be at different points in time is different. We also know that the stigma associated with the mental illness. And so we talk a lot with clients and with church members about this, and that it actually takes a lot of strength to go to therapy and counseling, that it's not something that you should be ashamed of, that everyone's faith, including mine, falters from time to time. That's part of the human experience. No one is, what I tell people in my church is, you don't need to be a superhero. You need to retire your cape, because we all need to realize, particularly now with COVID-19 and the racial and social injustice that is being highlighted right now, we all feel vulnerable and overwhelmed from time to time. So the important thing is to let people know that, but also sometimes people don't feel comfortable doing that. So we need to check on each other and make sure that we provide support for each other. Next slide. So the good news is that in faith communities, there's changes in the understanding of mental illness. There's less religious stigma associated. And people in faith communities understand better now that people sometimes have mental health challenges, and focus more on whether or not when people unfortunately complete suicide, whether that person was quote unquote operating under a sound mind, or whether that person was focusing or struggling with mental health challenges. Also, more and more now, mental health challenges are seen as a disease like any other disease, and it's not a reason to be ashamed or to think that it's a sign of God's disapproval. And also the silence is being broken, and clergy more and more are seeing their roles as partners with mental health professionals instead of adversaries. One of the things I share all the time is what we all want, we all have the same goal. We want people to live their optimal life. We want people to thrive. We don't want people to just survive. And sometimes people will say, I'm getting by. We don't want you to just get by. And from a faith perspective, you weren't created to just get by. You were created to really thrive and to live your optimal life and be your optimal self. We all want that. We have different tools to help people to achieve that. And so if we work together as a team, we can address the entire person and help them achieve those goals. Next slide. So this is some pictures from my church. This concept of mattering is really important. It's not just I accept you or I tolerate you, but I celebrate you. I rejoice with you. You make a difference in my life, and you make a difference in my community. And there are a lot of things that we do in faith communities that promote mattering. This is kids. We have kids doing Easter egg hunts. We have kids who every Halloween we have Hollyween, and we have a costume contest. So these are two little boys who were superheroes. We have game Sundays where we have a short, instead of having our full service, we have a short homily, we have some praise singing, and then we set up tables and we have food and people play games for kids, adults play games, we play all kinds of games. And it's just a way of saying, you matter to me, I'm glad you're here, and I celebrate who you are. And the contribution, just for being you that you make into this community. Next slide. Educational opportunities. We are a very education-focused church, and we are known for our work in social justice, and so we're particularly known for our work in environmental justice and also mental health, which I consider to be a social justice issue. And also, we are an LGBTQIA affirming church, which is unusual for a predominantly Black church. And so we do a lot of work and workshops about that, about sexuality in the Bible, about racism and environmental injustice in the Bible. So this is just some examples of forums that we had. This is me doing if you see that little slide on the bottom, what does the Bible say about suicide and mental illness? And so there's a series that we do on that. There's a series that we do on being an open and affirming church. So we have an 8-week series on sexuality in the church, which helps people to be more affirming of members of the LGBT community. Next slide. This is recently because we're practicing social distancing from COVID-19. As I said earlier, our church is not meeting in person, but we did come together with social distancing during Juneteenth to have a rally for Black Lives Matters. It was wonderful. It was about 30 of us out there, and our church is off of a very large highway, a 4-lane highway, and so one of my favorite pictures is if you see the baby on the left, my left. He has on a Black Lives Matters t-shirt. So that's Isaiah. He's just about to turn one in that picture. He's not even walking yet, and his dad is holding him up. The picture next to that is me and my oldest granddaughter, Michaela. We're doing that's why I was going to want to explain this, why we're not socially distanced, because she lives with us and my oldest daughter. So we were doing Black Lives Matters. We had a banner placed up, and then that's my youngest daughter holding the rainbow sign, talking about it's not just all Black Lives Matter. It's not just Black men or just Black women, but also Black queer lives matter as well. We had a great time. It was great for us to see each other. And so there are things you can do in your faith community that are affirming your culture through stories of how people overcome adversity and finding meaning in life's hardships. Okay, I think that's the last slide. Oh, every year, the National Action Alliance for Suicide Prevention you should go to that website, has lots and lots of great tools. Every year we do a National Weekend of Prayer for Faith, Hope, and Life, which is about suicide prevention. This year it was May 15th through 17th. It's always usually the second or third Sunday. It's third because we don't do it Mother's Day, in the month of May. And there are different ways you can do that. You can do liturgy, you can have programming. I always do a sermon about it. We do lessons about it. And so that's one of the things that you can also do. If you go to that website, or also SPRC has a great website. They actually have Suicide Prevention Resource Center. They actually have examples of sermons on that website. Next slide. So conclusion, it does really take a village, and it takes all of us from different walks of life, from different cultural backgrounds. We all have our own perspective. Each voice matters, each voice makes a difference. And thank you for asking me to participate.
All right. Thank you so much. Yeah, I'd like to thank all of our presenters for their wonderful presentations and all of that. Yeah, and all just so much wisdom dropped down today. Thank you so much, and experiences as well. I wanted to see whether I'm pretty sure that I see that chat has been going, and so I think one of our CSS staff, Kim, was going to be the one that's seeing what questions came up from chat. So if you guys could answer a few questions, that would be great. Kim, are you here?
I am here. This is Kim. I have a question for each one of your panelists. It's the same question. I'm starting with Felicia, then Mago, and then Sherry. Felicia, the first part of the question you kind of already answered, but it is what connects you to suicide prevention and mental health work? And then for each of you, the second part of that question is what keeps you going strong in your work? And Felicia, we can start with you, please.
Okay, So what connects me to want to do the suicide awareness work is because I've had 3 people in my family pass away from suicide. Also, I have several family members that deal with mental health. And so it's just been a stigma behind it for years. Nobody wants to talk about it. It's a taboo subject. People are embarrassed to talk about it. And I just like to let people know it's nothing to be embarrassed about. If you need help, reach out, ask someone. If someone asks you, you know, how you're feeling, you don't always have to say fine. You can tell people how you're feeling because you never know who you're telling it to and who may be able to offer you some assistance and get you some help.
Thank you. And Felicia, what keeps you strong in your work?
Just knowing that I could possibly save a life. And I mean, Mercedes knows that I'll reach out to her when I have a question, or if someone reaches out to me and I don't have the resources, Mercedes is my go-to person, and she knows that I will email her or text her, I need help. So that's what keeps me going. I can possibly save a life. And if it's just one, that's enough for me.
Thank you, Felicia. Mago?
So I think what connects me to this work, I kind of fell into it, but when I look back now that I'm in this job, I feel like there was a reason for me coming to this work. I think I have personal, academic, and professional connections to this work. I do have lived experience of some friends and family who have died by suicide. I kind of early on in my career, when I was trying to figure out what to do with my career, I spent 2 years in New York City volunteering as a suicide prevention hotline volunteer. And that was something that just it just spoke to me. I didn't really have a rational reason for why I wanted to do it. I just thought it would be a good experience. I studied psychology in college, and then later on got interested in public health. And then that's kind of where the intellectual side of things came. I got interested in how to address prevention of violence and injury from a public health perspective. And so that kind of, all of that kind of connects to the second question, which is what keeps me going. I think having that heart and brain connection in my work is really motivating. On any given day, I can be really inspired and motivated by an individual, we have so many passionate advocates in our community that work on this tirelessly as not part of their regular jobs. I was telling the organizers last night, we had a group of maybe 20 high school students who spent their entire day on Zoom for classes for school, and then 6 p.m. logged on for a training for 2 hours on mental health because they wanted to know how they could better support their friends and their peers. So that kind of thing at an individual level is really inspiring and motivating for me. But then when things get tough, I'm the kind of person where I'm always happy to also sit behind my desk and crunch data, and I find that comforting too, to go into my brain a little bit sometimes. So the combination of these two things are great for me.
Thank you so much, Mago. And Sherry?
So I think what connects me to the work probably is a million years ago when I first had my first academic job. I was actually studying, my dissertation was on chronic illness in adolescence. So I've always worked with young people. But I was supervising graduate students who were working in a counseling center. And I noticed that there were two things. One, that sometimes when I was just listening to the tapes, I could pick up on anxiety or signs of distress or despair in the client that the students were missing. And I was wondering about that. And I was also noticing that some of the students would make suicide attempts 1 or 2 days after they were in a counseling session, but never mentioned it in the counseling session. And that was particularly, after about 3 or 4 of those, you'd say, okay, something's wrong here because you're in therapy, but you're not talking to people about what's really bothering you. So I became really curious about who do people talk to when they're feeling that kind of despair. And when I first started doing this research, I was told by grant reviewers over and over again that I was wasting my time, that Black people didn't complete suicide. And since I knew that was not my personal and clinical experience, I tend to be the kind of person that goes, oh, really? And rolls up my sleeves and goes, I don't think so. So I always say it's an empirical question. So when I first started doing this research, I mean, literally, it was really hard to get funding because people kept saying you're wasting your time. And not just, people outside the Black community. Some of the most ardent people who objected to my work were Black people who said, you're pathologizing us once again. And I was saying, okay, but while we're afraid of how other people perceive us, people are dying. So we have to figure out how we can certainly talk about the strengths of this community, but also not ignore the fact that people are dying. And then what keeps me motivated is I belong to an organization called the National Organization of People of Color Against Suicide. And we do a lot of work with survivors. Survivors are people who have lost a loved one to suicide. And particularly when I see the way that this impacts the life of the family members, particularly moms, I always say I don't ever want to forget what that looks like, because I don't want any parent or any family member to go through this. And so sometimes when you get frustrated, or my students and I are looking and we can't get funding, or we're trying to do stuff, I make them look at the story, read the stories, look at the stories, hear the stories. That's why I think I'm so proud of you, Felicia. We need those stories to motivate us to not give up, because whether we get funding or not, this is an important issue. So people don't stop dying because we don't get funding. And so this has to be something that you're passionate about, and this has to be something that you're going to do, because the thing that makes me upset is that suicide is preventable. The 3 leading causes of death for young people, suicides, homicides, and accidents, are preventable. And when we have children in our communities who feel like life is not worth going on, that's not an indictment against the child, that's an indictment against the world they live in. And then we are the responsible adults that need to make the world different so that they can thrive in this world.
Thank you. In the chat, there's no more questions, but there's a comment from Shalitha, Assistas Touch, and she says, all of the information shared today was great. Thank you so much for creating this space of learning, engagement, and prevention. And with that, I'm going to turn it over to Mercedes. Thank you.
Thanks, Kim, and thanks to everyone that was on chat, and thank you for all of our participants today. And part of what we wanted to do with our series from our suicide prevention series was about building connection, building resilience, and most importantly, being able to provide hope in a time right now in our community and our society that doesn't feel, that may not feel very hopeful. So being able to have all of these reminders, and our daily reminders that hope is available, and that people are available to provide support, I think is really important. And I think each and every one of you were able to convey that today with your advocacy and what you're doing in your communities. Thank you so much again, and thank you again for all of our audience. And we're going to go ahead and end it here. Thank you.